All right. Are you guys able to see my screen?
Yes.
Oops. Yep. Thank you for the introduction, Dr. Maki. So this is a topic which is really close to my heart. So I'm going to try my best to keep it simple, straightforward, and to the point. So the way I want to structure this talk is to kind of go over the overlap between meditation and epilepsy. And we'll have a brief overview of meditation in the sense that what networks are involved, different types of meditation, and some EEG features of meditation in itself. And after that, I will go over epilepsy as a network disease, just like talking about different networks and the features that we see with epilepsy. And then we will go to the heart of the topic that I'm about to present today. And what is not covered in this talk is any sort of mechanisms, not electrophysiologically or biochemical changes associated with meditation or epilepsy. And I won't go into the details of statistical analyses, especially like those mathematical models that are used to understand the spectral display and everything. I'll keep it simple to the definitions. All right. So we're talking about meditation and epilepsy. So what is the connection between the two? Over the past decade, actually for years now, for several, maybe like decades also, across the world, I believe it's 73 or 74% of the neurologists across the world, they recommend some sort of meditation, relaxation practices for patients living with epilepsy, just not only because of their comorbidities, sure, depression, anxiety, some other, neuropsychiatric side effects associated with epilepsy itself. So a lot of neurologists across the world, they have been recommending meditation for this reason. Now, the reason is apart from improving the quality of life and the neuropsychiatric comorbidity management, there have been a few reports or papers about reductions in seizure frequency. And over the past few years, now we've seen that the risk is potentially high for increased risk or propensity of seizures during meditation, and that may be due to physiological alterations associated with meditation. So this is why now this has become a hot topic and everyone's investigating with larger, stronger evidence-based studies to go either or prove or disprove something. So talking about the networks involved in meditation. So there are three different networks of importance over here. Firstly, just to kind of talk about meditation in itself, you want that heightened state of awareness, and that's the main goal of meditation. And it's an umbrella term for different processes or different ways to kind of attain that state of mind. So a few networks, the three main networks that are actually involved in meditation are one, the default mode network. Now, this is your task negative network. So this is the network that is associated with mind wandering, right? And that is about 50% of your consciousness, mind wandering. So now with meditation, as we can see, it kind of reduces the activity of mind wandering. In fact, that is the whole objective of meditation, right? Now, the second network is the salience network. So this is the network that really helps with your attention. And the anatomic regions that are associated or part of this network are the anterior cingulate cortex and the insula. Now, during meditation, there is increased connectivity between the salience network and other brain structures that help in filtering out information just based on your attention. And then the third network that is involved is called the executive control network. And pretty much all your executive functions, right? Like your cognitive control, decision-making skills, and goal-directed behavior. So naturally, meditation enhances the connectivity, leading to improved attentional control and emotional regulation. So I have referenced the study in the footer and all the other studies that I have referenced to give this talk. So please feel free to look at it in detail. Now, epilepsy is network disease, right? So there are several networks, and we have some evidence based on the studies that have been done in both epilepsy patients as well as like normal neuroscientific studies, right? And certain networks we know are disturbed or there's abnormal connectivity, and the kind of deficits or the kind of manifestation that we can see with certain networks. For example, the default mode network, right? We spoke about that. Now, in patients with epilepsy, there can be abnormal connectivity, and that contributes to cognitive deficits and altered consciousness during seizures. Next, the salience network that may contribute to abnormalities in attention and perception in patients with epilepsy. The thalamocortical networks, again, disruption in these networks can contribute to the generation and propagation of seizures in different ways. And then you have the frontoparietal network. Disruptions of this network in epilepsy, again, with the cognitive impairments. This is one of the things that's commonly seen. Sensory motor, that contributes to your seizure semiology, like the jerking movements of the hand, the stiffness. So when these networks are in action, this is something, the semiological features that we see. And of course, the limbic network that is very popular in the field of epilepsy itself. Your emotion, memory formation, and we've seen that with in patients with temporal lobe epilepsy especially. You see trouble with memory, as well as some sort of emotional imbalances and stuff. And limbic network is one of the things that's highly, highly thought of or associated, or involved rather. I'm going to skim through this really quick because there are different types of meditation. That's not the objective of the talk. So I'm going to talk about it really quick. Like I said, meditation is an umbrella term. The pathway to this destination is different, like several different things. One of the commonest and most common and very well studied form of meditation is mindfulness meditation. So you're just being mindful of either your breath or any sort of sensation, your thoughts. You're just like internal awareness without any sort of judgment or without, dwelling on that one single thought or single sensation. Then you have the transcendental meditation, which uses this mantra, like it could be a word, a sound, or a phrase. You keep chanting with the idea of engaging your mind in those chants or the mantras itself. And you get this state of transcendence, which is a totally different feeling compared to the other forms of meditation. Then you have the pranayama meditation, which is essentially breathing exercises, different types of breathing exercises in different frequency, pattern, everything to focus on each and every aspect of the breath work itself. And that is commonly, that goes hand in hand with yoga. Then you have the loving and kindness, heart opening meditation, which is all about love and compassion. You see the union in the world, that kind of meditation. Then your focus attention, another commonly studied both in epilepsy world as well as the correlation of meditation and epilepsy. So focused attention, it could be the breath, it could be the candle flame, visual image, could be any sort of focus, right? Now, I don't know the difference between mindfulness and focused attention. Next is the body scanning meditation, different visualization techniques, and Zen meditation, Vipassana meditation, mindfulness-based techniques as well. So next we'll talk about the EEG features or the electrophysiology of meditation in itself. So common things, of course, it depends on the type of meditation, what you're focusing on, or are you not focusing on something, right? And it also depends on the duration. Of course, it's going to be different if I just do 10 minutes of meditation today and I don't meditate for years, right? Versus me being a practiced like a consistent meditation practitioner. So the longitudinal data or the longitudinal wiring also comes into picture when we talk about meditation, experienced versus non-experienced meditators. So a few common things are increased alpha and theta activity in the brain. That's associated with relaxation and high attention. Mainly you see them in the frontal and parietal lobes, right? And alpha, you think about alpha in a very relaxed but an alert state. And you see theta more in like the depth of meditation and during deep relaxation. Next, the beta activity, which is, associated with active thinking and concentration in itself, that is known to decrease during meditation, as intuitive as it sounds, right? So this reduction, that kind of produces this relaxation by reducing the mental activity. Then the third thing is synchronization of the hemispheres. There's increased coherence between the two hemispheres, and you see that based on the increased alpha and theta coherences in the frontal and the parietal region. And this is one of the things that is associated with improved cognitive and emotional regulation. Then frontal asymmetry. There have been studies that reported changes in the frontal asymmetry during meditation, more so with increased activity in the left prefrontal cortex, mainly with, positive emotions and approach-related behaviors. Now, this shift in the frontal asymmetry, that may contribute to the mood-enhancing effects of meditation. Next is your gamma oscillations. So now we're talking about the expertise, right? Like in advanced meditation practitioners, they may exhibit high frequency of gamma oscillation, like 30 to 100 hertz, maybe even more. So they're associated with higher cognitive functions such as attention, memory, and consciousness. Now, these gamma oscillations, they reflect a state of heightened mental focus and awareness, which is the main objective of meditation. Then the other temporal dynamics are, of course, they vary with time, like I said before. Different phases are characterized by distinct brainwave frequencies, like at the beginning of the meditation, the height of the meditation, what phase of meditation you're in, right? And even the synchrony changes based on what phase of meditation you're in. For example, in the initial stages, there is increased theta activity, but as you go deeper and deeper, there is increased coherence of the alpha and gamma oscillations. Switching gears, we'll talk about the actual topic, which is the influence of mindfulness meditation on intracranial parameters in epileptic and non-epileptic brain tissue. Now, the objective of the study was to describe the spectral changes from stereo or intracranial EEG with electrodes in the hippocampus and amygdala during mind wandering versus mindfulness meditation, and also looking at the differences between epileptic and non-epileptic tissue and seeing how the electrophysiology differs during meditation/mind wandering in either or. So in two of these things across two parameters. So again, just really quickly, mind wandering, right? So this is your spontaneous state of thoughts. Now, without any external stimuli, this is 50% of your wakeful consciousness, right? And then the functional MRI studies that have looked at or examined patients or people who have mind wandering, they've demonstrated a predominant role of the default mode network, the task negative network. And the hippocampus may also play a critical role by mediating the imagined events of the past or future, your mind's wandering. And then the mindfulness meditation, right? When you're focusing on the single stimuli, there is reduction in amygdala activity as well as the functional connectivity during the mindfulness meditation. Now, the pros and cons, right? Like you have the scalp EEG, which, yes, gives you data about, okay, coherence, like what the brain waves generally are and all that, but it does not give you the spectral changes between the states. And it does not kind of give you or give an assessment of the deeper structures. And the fMRI, it lacks the high spatiotemporal resolution. So due to this, like the best and obviously the gold standard would be to look at the depth, the deeper structures with intracranial, less noise, just deeper in, get the data kind of a picture. Now, like we spoke about before, there's definitely mixed literature. Meditation could increase the propensity for seizures. Some studies have actually shown reduced seizure frequency with meditation itself. So in this study, it was a small sample size of 8 patients. Now, these 8 patients, all of them had drug-resistant focal epilepsy, and they went for stereo EEG for seizure localization. And all of them had mesial temporal lobe epilepsy. All these patients had amygdalar and hippocampal leads. The epileptogenic versus non-epileptic epileptogenic tissue was based on the SEEG review, in that the non-epileptic MTL was non-lesional and did not have any ictal or interictal activity. Then you have your epileptic MTL, where the contacts of the electrode, they were in the seizure onset zone and or actually had interictal epileptiform discharges. So here's a picture of where the intracranial electrodes were located exactly. 8 patients, a total of 65 contacts, 45 in non-epileptic MTL and 20 in the MTL, epileptic MTL. And there were 23 in the amygdala and 42 contacts in the hippocampus. So for the intervention, there was guided mindfulness sessions. So it was structured in such a way that you focus on your breath for 10 minutes, look at the EEG changes, and then you see 2 minutes of mind wandering. So you see the difference between the two. And there's this questionnaire, it's a 30-item questionnaire to kind of assess the depth of meditation. And what they would do is provide this questionnaire to get an idea of how deep the patient thought the meditation was. Now, for the intracranial EEG data, there were 2 components, right? One is the periodic component, which is your baseline, your rhythmic or oscillatory frequencies. And then you have the periodic components, which is pretty much a background activity, like baseline background activity. Now, the periodic components, they were compared in frequency bands, normal theta range, alpha range, beta range, and gamma. That was limited to 55 hertz, and they were not, beyond 55 hertz was filtered out just to kind of, because of artifacts, and they did not want to confound the data. And with regards to the aperiodic components, they were analyzed by this aperiodic model itself, and we will talk about it a little more in the next few slides. So since we spoke about all this, let's go straight into definitions. So when we're talking about the aperiodic onset, we're talking about the baseline power of the neural signals across all frequencies. It's your baseline. Now, a higher offset that suggests overall increased neural activity or excitability. And then you have the aperiodic knee. It is the frequency at which the power spectrum transitions from a flatter region to a steeper decline. So as you can imagine, all the higher frequencies, they have higher amplitude, right? Like your deltas and everything, higher amplitude. They are lower frequencies, right? Higher amplitude. And naturally, as the frequencies transition, the decline is seen because of the amplitude change. Delta being higher amplitude and the faster frequencies being lower amplitude. So the knee that they're looking at is the transition point from the flatter or the lower frequencies to the higher frequencies. And naturally, higher frequency or higher knee frequency, it suggests increased contribution of low frequency activity. And then there's this aperiodic exponent, which is the slope of the power spectrum on a log-log plot. So that reflects the balance between the lower and higher frequencies. So pretty much. So a steeper or a more negative exponent means greater suppression. So here's the first graph of the study. So in orange color or whatever color that is, that's epileptic. And the greenish blue box is the non-epileptic. And what we have on the y-axis is the difference in the power between mind-wandering EEG spectrum and mindfulness spectrum. So as you can see, theta, alpha, beta were not really significant. The only significant difference here was between the gamma power of epilepsy, epileptic tissue, and non-epileptic tissue. So compared to the epileptic contacts, the non-epileptic contacts, they had significantly greater reduction in peak gamma power. And that's with mindfulness meditation compared to mind wandering. There were no significant differences between any other conditions across the other bands. There was no significant difference in powers across any of the frequency bands between mindfulness meditation and mind wandering. Now, after we spoke about those definitions, I think it makes more sense that we can understand based on these graphs. Clearly, there was a higher aperiodic offset in the epileptic compared to non-epileptic. Same thing with the knee and with the exponent as well. However, we will interpret this a little differently. So the differences in the aperiodic activity, right? Like based on the results, they were all significantly higher in the epileptic tissue during meditation compared to mind wandering. So in the epileptic regions, 90% of the contacts, they showed a higher offset, right? And 75% of the contacts showed higher knee, and 80% of the contacts showed a higher exponent. So to summarize, what this means is that the differences between mindfulness and mind wandering was stronger in the epileptic regions than in the non-epileptic regions. Now, in the non-epileptic contacts, these were not really different. There was no significant difference in the components of the aperiodic model. Mind wandering showed higher gamma power in 87% of non-epileptic contact, meaning the brain activity in the gamma frequency was generally greater during mind wandering than during mindfulness meditation. Now, the contact pairs were evenly distributed across all patients. Each patient had similar number of electrode placement. And the reason that I'm bringing this up is because that kind of helps us determine that the results were consistent across the groups. Now, we spoke about the patients having, or the study participants having leads within the hippocampus and amygdala. Now, did that make a difference? So there was no significant differences between mindfulness and mind wandering that was attributable to the electrode placement. So it was really consistent across the brain regions. There were about 42 contacts in hippocampus and 23 contacts in the amygdala. Spectrograms. So this is all in the non-epileptic hippocampus. On the left-hand side is mindfulness meditation, and the right-hand side is mind wandering. As you can see, there is increased activity of gamma during mind wandering compared to mindfulness. And there's minimal activity seen at higher frequency during the mindfulness meditation. compared to mind wandering. So remember in the study, after each session, the participants were required to fill out this questionnaire. And this data out of the eight participants was only available for 6 of them. Now, the average meditation depth score on this questionnaire was 57.7. It is higher than the reported average, which is 45 for naive meditators. Now, individual scores ranged from 16 to 88. There was a huge variability in the meditation experience or the effectiveness among participants. So that's one factor to kind of consider. Now, regardless, there was no significant effect of meditation depth on gamma power. But there was a difference in the aperiodic components. So the aperiodic offset, that decreased with deeper meditation. And the aperiodic knee, that also decreased significantly with during meditation. Only thing that did not show a significant change was the aperiodic exponent. So the strength of this study is that it's an intracranial study, so that gives us more accurate view or more accurate information about the structures, less noise, more data, more reliable data, I must say, compared to the scalp EEGs. But one of the limitations is that the sample size, 8 participants, is quite low. And then you have like the study actually filtered out the higher frequencies over 55 hertz. So that's another thing. So maybe there was more results that was more significant differences if higher frequencies were compared, but that's one of the limitations that the authors acknowledge. Now, this mind wandering for 2 minutes that the study had proposed, that was subjective. There could be other things there could be other things done to see if indeed there was some sort of mind wandering, to kind of something like, monitoring the eye movement, maybe something like that could potentially help more than just like a subjective thought about, oh, okay, if somebody's is like actually meditating or is their mind wandering kind of a thing. And then the big thing is, clearly we know, or based on the studies that we have seen, there is a difference between a naive and an experienced meditator. So unfortunately, since this data only looked at naive meditators, what can we say about the long-term consequences? And the duration of observation was very brief. So do we get like reliable data? That was another thought that I had. So from this talk, I think the big take-home messages is that, sure, there is an increase in gamma power in the non-epileptic regions, and that's consistent across individuals. Aperiodic components, there is an increase showing a distinct pattern of activity in seizure-prone areas of the brain. And brain region not having a significant impact on the findings itself. That kind of suggests that a broader network level effect rather than a regional specific one. And the analysis kind of strengthens the evidence that mindfulness and mind wandering, they engage in different neural mechanisms, particularly in patients with epilepsy. So what does that mean? Does meditation actually increase the propensity? Like, do we have sufficient evidence to say that based on these findings, it could potentially increase the propensity to have seizures? Maybe, maybe not. Does it depend on the type of epilepsy for that matter? Few questions. That's all I have. I would love to hear any thoughts, ideas, or questions.
Thank you, Par, for this special topic, interesting special topic. It's different from, the classic topics we cover. Now, can you go back to the different frequencies and your initial slides, like the gamma and
The electrophysiology of meditation.
Yeah, yes.
Sure.
And about synchrony.
Yes.
So how did they study? I mean, I'm sorry, I'm not very kind of knowledgeable about this topic, but how did they study like the different frequencies and with synchronization and the effect and the different effects of the different frequencies? Can you tell me more
Yeah.
about it?
Yeah, for sure. So in this study especially, so what they did was they had experienced meditators, right? And they did scalp EEG.
Hmm.
So pretty much like they analyzed the spectral frequency, pretty much like the heat wave map and the coherence data, pretty much like the Curry data. So
Hmm.
they looked at the power of these frequencies. It's called frequency time decomposition or something.
Hmm.
So it's like a mathematical model where different frequencies are drawn out and kind of measured, like what frequency you have, how much of this frequency and how much of that frequency. So it's pretty much like a mathematical model.
Hmm.
And based on that, they looked at which of these frequencies is increased.
Hmm.
Yeah. So, and even the coherence was based on the spectral analysis itself.
And how did they know that, let's say, like synchronization would be uh, associated with improved cognitive function? Did they kind of compare? How did they study that?
I am not too sure about this.
That's
I'd have
okay.
to look back. Yeah, but great questions, Dr. McKee.
And my other question is for the invasive ones, like in the paper. Did they
Hmm.
compare like whether they were on specific medication or not, or they did not provide this
No,
information?
no, they did not provide this information. They just mentioned that they're undergoing pre-surgical or like seizure localization. They just mentioned that it's refractory
Mm.
focal epilepsy. That's a very good thought too. I have to make notes of this because again, like there are so many things that are confounding in
Mhm.
this study, and we don't have all the information. So I think this is a great point.
And how do you see like mindfulness meditation be like applied in clinical care, let's say? Do you think there is a role?
I certainly think there is. And I'm not biased, but at least based on everything that I've read, just literature review, not particularly in patients with epilepsy itself, there is compelling evidence to state that depression, quality of life itself improves a lot because you can think about it directly or indirectly itself. One is the kind of comorbidities, especially in our patient population, the kind of comorbidities, be it medication related, not medication related, if this is some sort of a personality trait or personality or disorder itself, one, it kind of helps from that perspective and improves the quality of life. So, from that perspective, I think it's really, really helpful.
Hmm.
And two, I want to believe that the seizure frequency reduced. But again, when you're applying this, would I feel very comfortable in applying to patients with epilepsy after having reviewed this? Maybe, maybe not. This is something that I would discuss with the patients itself, saying that there is data on both sides, but it's not strong. But it's worth a try, I think.
Hmm.
And to talk about more, there are like two other studies, Dr. Maki. One is a pilot study that was done, kind of more like a feasible study. They have three arms. One is mindfulness meditation, like different depths of meditation, and a control group. And they're including all patients with epilepsy. And I think this is done off of a French institution, like a French university. So I'm curious to see what kind of data we're going to get with that study. And the other study that's ongoing, or yeah, I think that's ongoing, is chronic electrocardiography in patients with epilepsy. So patients with RNS implantation, subject to meditation, and you have like long-term data available. So to go back to your question, I would still recommend meditation, just simply from the quality of life aspect. And yeah,
So overall, for better well-being.
yeah.
Okay.
And the stress levels, the cortisol. anti-aging properties.
So we
And
need to have more knowledge about possible effect on seizures. We don't know. Yeah.
yeah,
Okay.
this hypersynchrony, coherence, all that makes us think, oh yeah, it is definitely possible. But my thought is, if the network is already disrupted, can meditation actually help fix it? Is this something that's seen, and is this a feature of the disease tissue itself? Or, I mean, are we overreading it, is what I'm trying to say.
Mhm. All right. Well, thank you. Let me see if there is any. I don't see messages or questions in the chat box, but please feel free if anyone has any questions or comments to unmute and share your thoughts and questions. All right. I also posted the CME code. I'm going to repost it again. And as we always do, the videos will be posted soon.